Welcome to the Fabulous Fifties and Beyond. I'm Jim Pollard, your co-host with my wife, Jeanetta. Today we're going to be talking about the Lourdes Hospice Program in Western Kentucky, the need for volunteers. And we want you to stay tuned as our guest is the nursing director, and we're going to talk about the different parts, the team aspect of hospice, and where you might be able to fit into the program. You stay tuned and we'll be right back.
And he'd say, go with what you got. Start from where you are. Give it your best shot. Keep reaching for that star. Get in the race. Keep your own pace. Keep moving and never stop. Just go. Go with what you got.
I'm Jim Pollard, your co-host with my wife, Jeanetta. Today our guest is Reta Lewis, and Reta is the Patient Care Coordinator for the Lourdes Hospice Program in Western Kentucky. Big title. That and 50 cents to get you a cup of coffee, or is it $1 now?
Maybe $1.
Reta, welcome, and we're glad to have
you
you with us to talk about hospice in Western Kentucky. It's, you know, and as we've seen, hospice to a lot of people is something new. And there are a lot of people out there that don't know what hospice does. They don't know who it's for. And we've had a good education in it over the last few weeks ourselves as we've gone through our 8 hours of classroom training on what hospice is and what it does. So tell us a little bit about the team approach and the nursing part of hospice, if you would.
Thank you, and thank you for the opportunity to get to share that. I'll start with what hospice is overall, and it's a model of care designed for people with life-limiting illness. Our approach is a core interdisciplinary team approach of professionals and volunteers. Our goal is to provide physical, emotional, social, and spiritual support to the patient and to the families. We mostly are in care for patients in the home, in the nursing home. We do have other levels of care, which include inpatient care if that's necessary, and a respite care, which would be a stay to give folks a break if they needed a respite stay. The team consists, first of all, of the patient and family. They're the core part of the team. We work with their physician and our medical directors to direct their care for any control of symptoms or pain or whatever might be needed to help them to live every day to the fullest that they possibly can. Patients with hospice do not have to be homebound. We try to encourage them to get out and do as much as they possibly can and feel like doing. When you sign on for hospice, you get the whole ball of wax, we call it, the team, which includes not only the physician but a nurse. Nursing aides are available for personal care. We have social workers, chaplains, and then volunteers. And we all work together. We have team meetings every 2 weeks to discuss our patient care, ways that we can improve what we're doing, but do truly function as a team for whatever's needed for a patient, the family, and the home, and what we can be doing for them.
One of the things that we discussed, and maybe you should talk about, is the difference in hospice and home care, because hospice does different things than home care. Some things are similar. Sure. But then there are different things that they do.
Some of the differences with it, let me start with the similarities. Some of the similarities are that we go into the home and we provide nursing care. As I said earlier, there is a homebound status required for home care, not for hospice. And we're usually treating patients who are no longer seeking really aggressive treatments or curative measures. But as far as having in-home services, a lot the same with nursing. We do offer the volunteer support and some other things that they don't in home care.
Now, you help with nutrition?
We do.
Medication?
We do. If a patient elects hospice, we provide any durable medical equipment they might need. Also provide any medications that are related to their terminal illness that we're admitted for. So besides our services, we cover also those things.
We might want to mention that most insurances plus Medicare would cover hospice care.
There is a benefit through Medicare and Medicaid. Many private insurances have, clauses and benefits for hospice. And then if someone were to not have any coverage at all, we We'll admit anyone to our program who qualifies regardless of their ability to pay. And then we have our team work with them usually to find some resources, hopefully to cover their care.
Well, that's good, that you will help them
Right.
with that. Because, the financial part can be a terrible struggle
Right.
when people have
Right. And at
these
that time of their
diseases.
life, that's something they shouldn't have to really worry
Right.
about.
Right.
In the nurses visit how often?
All of hospice care is based on need. There isn't really a set of hard, fast rules. We go in initially after we admit a patient. All of the disciplines will go in and determine their schedule of frequency for visits. The chaplain may need to see them more frequently if there's issues for him. Generally, once to twice a week is where we start with. If a patient's having issues or symptoms or is in trouble or having some kind of crisis, the nurse may visit them every day, strictly based on need. But that can change, if they get leveled out and they're doing better. On average, a couple of visits a week from a nurse. Nurse aides can visit anywhere from 1 to 5 times a week, depending on the need for some personal care and some assistance there. And then the social worker and chaplains usually determine their own frequency based on what their assessments are.
Now let's talk about the respite care for a minute. Now that's where the volunteers come in.
Yes.
Because this is like, if you have a loved one that you can't leave, you need to get away.
Yes.
The family needs a break.
It's a wonderful thing that we can offer volunteers to people. Our volunteers are usually revered by our patients because they have time to go in and sit and visit and really get a relationship with these folks. It provides a wonderful service to our families who may need to run to the grocery or run to the bank or run errands, but just doesn't feel comfortable to leave that person alone. And they can have a volunteer come in and do that. There's many other ways that our volunteers serve, though, other than going to the home and just sitting at the bedside. Whatever talents someone might have, I promise we could use them. We've had music therapy and people that wanted to go into the nursing facilities and play instruments, working in our office for some clerical support if they prefer not to do direct patient care, running errands or picking up medications to be delivered or cooking a meal, many, many ways that they can serve. And the volunteers get close to the patients and have an opportunity to really share, some time and their gifts with them. A personal experience I had with my father when we had him in hospice in Missouri is out of all the hospice team, and they were wonderful. I think the volunteer was his favorite person because when that gentleman came out to visit him, he got to sit and talk about work and all the things that he wouldn't tell the nurse.
Right.
Yeah. I know I think we kind of skimmed over it in the beginning, but one of the things that I think our people need to know about is that hospice is not just for cancer.
Yeah, thank you for mentioning that. I just want to scream from the rooftops sometimes because we want to get that word out. And many people today still believe that hospice is just for cancer patients, and it isn't. Any person with a life-limiting illness could have hospice care, and many people aren't getting it because of that. They don't understand that it can be available to them. Renal disease, end-stage lung disease, heart disease, Alzheimer's disease, a multitude of chronic illnesses. The qualifying factor just has to be that a physician is willing to certify that this patient is within likely the last 6 months of their life.
Let me interrupt you
Sure.
just a minute there because that's not an easy thing for a doctor to make a decision to say either, is it?
Right, it isn't. And maybe that's the reason sometimes for later referrals because they want to feel certain before they make that statement. But we are regulated and have to make certain that patients do qualify. If someone, it's a great day in hospice when somebody gets discharged. I mean, maybe we brought them into the program with really good care and their illness has leveled off and they're doing well. If they're not meeting the criteria at each recertification period, we may discharge a patient, bring them in later if they, decline again. We always celebrate a day when somebody is discharged, but physicians do, I think, tread lightly there sometimes, but what we can do to help with that is constantly evaluate their appropriateness. And
Well, it's good that you brought up the discharge, because I'm sure that a lot of people think when you go in hospice, it's final.
That's
it's not
it.
true.
That's it.
It's not
but
true.
It's not true.
It
See?
isn't.
Right.
Yes.
And that's another thing that people need to understand, that people, one of the things that we talked about was that if somebody said, well, I heard of this new treatment down in Nashville or in Louisville and I would like to go check it out, then that's possible. They just write them out of the program and they go do it and try it out.
Exactly.
But they do have to be written out of the program before they can seek
Right.
to do what kind of care? you call
Aggressive
it?
care.
Aggressive
If there is
care.
something that
Right.
comes up and someone would like to go back into that or try it, absolutely. It's a personal choice. That's why hospice gives people control over their care and treatment.
Right.
They would just sign a revocation and sign out of the program, and then we would readmit them should they choose to come back in at a later time.
Right, and that's good, you know, because sometimes you get kicked out of a program, you can't get back
Sure.
in it.
And sometimes it's not easy to get out of a program.
Yeah.
You know, and I think these are things that the public need to know about hospice.
Because I think that's one reason people would hesitate to put them in there if they thought that if they didn't know that they could
Right.
get out.
Right. Well, and people need to know that they're in control of their end-of-life care. You know,
Yes.
it's all about them and the choices they want to make, and we're there to assist with that. But, you know, to palliate symptoms and keep them comfortable and help them find some quality, that's what we're all about. But they all have a lot of personal choices, and they're the ones who are the core of the team, who help drive their care.
And that's as it should be, because, you know, you say what you would do, what you think you would do, but until you're there, you don't know what you would do.
Right.
So,
Right.
I'm a prime example of that. Several years ago, I had my knee replaced. Well, let's see, it would be 4 years ago, almost 5. And, you know, you talk about, what do they call them?
do not resuscitate.
Yeah, the DNRs and the living wills and all that. And you can talk about it all you want to, but then when they lay that paper in front of you for you to sign, I said, I signed it, but but it's just that, you know, the rubber just hit the road.
Right.
But you do have a choice to sign whether or not
Right.
you want them resuscitated.
And that's another myth maybe we can dispel, is that many people think if you have hospice care, you have to be a DNR.
Right.
And that's not true. It's still a person's personal choice. We admit patients all the time who are still a full code, a full resuscitate. We educate them, we give them opportunities to, know their options, but it's still their choice.
Right.
And if, they were to decline and wish to go to the hospital and say, I just want everything possibly done, there again, that's their choice. We would revoke our hospice benefit and they could choose to do what they wished.
Good. Rita, we're going to take a break.
Okay.
And after this short break, then we'll come back and we'll continue in our discussion of the nursing part and the overall part of hospice. And remember, they need volunteers.
We didn't have much to give then. So when they showed up, firing them mean looks around the place and staring us down on prices, well, I was angry. Didn't seem to bother my father, though. He had me load another bushel of apples in their trunk. I learned later on that this family was in need.
The greatest gift we give, it's in our heart, what we believe, the way we live.
Caring for others. Pass it on.
And he'd say, go with what you got. Start from where you are. Give it your best shot. Keep reaching for that star. Get in the race. Keep your own pace. Keep moving and never stop. Just go. Go with what you got.
I'm Jim Pollard, your co-host, with my wife, Jeanetta. Our guest today is Reta Lewis from the Lourdes Hospice Program. She is the patient care coordinator, and we're talking about hospice in Western Kentucky and what it does. And we also want to continue to emphasize to you the need for volunteers And the volunteers are in all aspects of the work. It can be clerical, it can be administrative, it can be any type of office work, it can be driving a vehicle, shopping. It's not only person-to-person direct contact with the people out there. So if you have some time, and we would love for you to call the coordinator, the volunteer coordinator, and that's Susan Mason, and we would encourage you to call her and offer your services. It's a rewarding work that I'm sure you'd love to take part in. So Reta, let's talk more about the nursing aspect, or you said you want to talk about some of the nursing things that they do, and then the LIVE program, I think.
Okay. Well, we spoke earlier of the team of people. Nursing aspects are just to do an assessment on patients each visit, make sure that their symptoms are controlled, work closely with the physician to see if things need to be changed or titrated. Nurse aides can do, and I didn't mention this earlier, personal care to help the patient and the family, and also some housekeeping if necessary. And a lot of people don't think that we do much aggressive care, and we don't do aggressive treatment. I guess what I'd like to say is that if a patient does need IV fluids, we can provide that at home. We have done some palliative radiation for patients, and I think in the past there's been a myth that, you know, when you sign in for hospice, they're not going to do anything. But it depends on what patients need. We do palliative radiation, we can do IV therapy, pretty much whatever we could consider as palliative care to make them comfortable.
Now, let me play the dummy.
Okay.
Define palliative.
Palliative is something that is not curative. Maybe you're not seeking this radiation treatment to cure your cancer, but if someone has a tumor that is causing pain, that we could do what we call palliative radiation to maybe shrink a tumor, that would be comfort. That would be considered a comfort measure. Many things could go either way, whether it be palliative or curative, and it just, you have to take a look at it and decide, is this really going to help just be a comfort measure?
Mm-hmm. Okay. All right. I'm one that sometimes I don't know the difference. I'll ask, if I don't. I mean, you hear the term a lot.
Right.
That's the thing about
And we
it.
have some hospice patients too that need, we also provide therapy. It's not something we advocate for. We don't do aggressive therapy because we don't expect patients to always rehab. But if someone needs a physical therapy eval to help teach the family how to transfer, how to ambulate, we can do physical therapy evaluations, OT, speech. We have a dietitian available for consults if need be. So many aspects in the medical part available to people.
Well, the dietitian would be if they need special diets or
Right.
or if they have a problem swallowing or things like
Yes,
this.
diet modifications, those kinds of things. We can use their expertise to help us find out what's going to work best for the patient. Sometimes we have patients that are on feeding tubes that we may need to have, a consult with someone to make sure that that's adjusted properly and they're getting what they need, or maybe it needs to be decreased or for whatever reason, but we have that as a consult if need be.
A couple things. One thing that was emphasized to us, and we talk about preparing a meal or different things, but the hospice volunteer does not feed.
Right.
That was one thing, and we understand fully why, but they need to understand. Another thing that I did not know until I got involved in the program is that hospice also works in the nursing homes.
Yes.
For some reason, in my mind, I always thought that it was strictly a home care.
But it's also
provision.
hospitals. Don't
Mhm.
you go into hospitals
You do the
too.
hospitals
If we
too?
have someone who is in an acute inpatient status, and we do inpatient hospice, most of our care is at home in the nursing home. But if they have a need to be in the hospital, yes, we do hospice care in the hospital as well.
And so the general public needs to understand that it is for nursing
Right.
homes also.
Right. We have a large population actually in our program of nursing home patients in this area, and that's where I think another big place that the volunteers can make such a difference because, as we know, sometimes folks in the nursing home don't get a lot of visitors. Their families work and they have, not enough opportunities to get there to visit, and sometimes just going and visiting with someone, reading to them, taking them out for a wheelchair ride, just being, a companion to them can make such a difference. So there's a big opportunity, I think, in the facilities. And as you said, we don't feed the patients, but many of them may just need help setting up their tray, getting their meals ready, and those kind of things can make such a difference.
Just opening their milk or
Yes.
their, anything like that. And they are some very lonely people in the
Yeah.
nursing homes.
Yeah, and they welcome anyone that wants to come
Yes,
and
they
visit.
do.
They love it for someone to come and just sit with them and read. And you find out what people's likes are, and you find out about them. One of my favorite things is just to listen to people tell about their lives. Just to be a
Isn't it
listening,
interesting?
listening presence and hear, about their lives.
And I think you have to be willing to hear the same stories over and over and over, and
Yeah.
not let it bother you.
Right. That's
Because
true.
this is what they do.
Mhm.
This is
Right.
and they remember things years ago where they can't remember sometimes things that happened yesterday.
Yeah.
Talking about just visiting them, and back in the early to mid 60s, before there were nursing homes were prevalent like they are today, I worked at Baptist Hospital in Nashville. I was in their male nursing technician class, first one they ever had, and it was quite an experience, because some of the head nurses did not want us on their floor at all, because men on the floor, working as a nurse. And some of them welcomed us. The orthopedic floor just welcomed us to be there to lift their patients in and out of bed. And there was one wing at Baptist that was like a sun porch, and it was nursing home type patients. And I used to have to go in there and take different ones out of the bed and set them in a chair for a certain period of time. And I got tickled that I'd walk in the room, and one of the older ladies would say, "Here comes that good-looking man. You get to hug his neck again," because I'd helping them out. They were holding, and they thought that was the greatest thing in the world, and it was a big joke and a lot of fun. But they do. They just like to visit. And I know when her mother was in the nursing home, I'd go through there and they'd say, "Here comes Santa Claus. He's coming to see us again today."
Right.
And the different things like
And we
that.
have a need, I think, too, for more male volunteers.
Yes.
We have, a large volunteer base, but men relate so much more, I think, to men. And as I said earlier, my father, he loved that his volunteer was a man and they could talk about work and motors and, things
Right.
like that.
Right.
But we have a need for male volunteers to visit with some of our gentlemen and have more in common with them.
Right.
And they'd love if you bring children. And I think even some of the nursing homes let you bring your animals.
Yeah, many of them like pets.
And they love it.
And will welcome pets, and you could take that with you. And I guess one thing I enjoy seeing out of that is not only our hospice patients benefit from that, anybody in the facility that you walk past or is within
Right.
earshot
Right.
can
Yeah.
really benefit from
Right.
that. And that's nice for everybody to be able to enjoy.
Yeah, I was visiting somebody at the hospital last year, and they were having a test run, and I was in the hall, and there was this other family gathering in the room. They're such a huge family, and they were there for an older lady who was mother, grandmother, great-grandmother, They were
Right.
all out there. And so they talked about me being Santa Claus, and they said, "Well, if she comes in, we want you to go in and see her." And so when she got back in, they went and said, "Somebody's out here wants to see you." And so I went in there and told her it was Santa Claus. And somebody says, "Well, what do you want from him?" And she says, "Just a hug and a kiss." And so I went over and did that, and that's the greatest thing in the world,
She probably
for-
talked about that for days.
Yeah. So, but like you say, it's just, and we've talked about how little sometimes it takes to make people stay.
You don't know when you cross paths with someone the difference that you might be making, whether you're just walking down the hall with your animal to go visit somebody, how many other lives you might touch on the way. And I think that's one thing too, just to plug for volunteers. It's hard sometimes to get up and get out and make yourself do that, but the reward is there, and it's so special to see the good and to be rewarded for that, because you make a big difference in people's lives. And even those little things, a phone call to somebody sometimes just to say, "You were on my mind, how are you, I was thinking about you," can make a huge difference to people.
I laughed. I've been in a lot of different businesses. My wife says, "What haven't I done?" And we were in the garbage business one time, and we had people that if the collector wasn't there at the same time, they were calling wanting to know where they were. And I was in the post office one day, and this guy, the postmaster, was saying, yes, they'll be there. They're just running a little late today. On. I said, you get those calls too? He said, oh yeah. He said, we have people that are at home by themselves, and if the mailman is regular time is 10 o'clock, if he's not there at 10 o'clock, they want somebody to call and talk to him. Want to know where he is.
That's important.
They, you know, and some people have even called the police to get somebody to talk to, you know, because they are so lonely.
And someone that is at the end of life, usually in that situation, they want to talk. They want to talk about their life. They want to review their life. They want to look for some closure, and they enjoy just being able to tell people their story. And oftentimes, all you have to do is listen.
Yeah.
And that's all they need.
Yeah, just a listener.
Right.
Yeah.
And sometimes I say it's so interesting, though, some of their
is.
stories. It really is.
You'll learn a lot and take away a lot from it. You know, people just want to give and give and give of their life and review it. And I've learned a lot and been impressed by some of the things that I found out that you don't expect to come from a person that maybe they've experienced when you take time to really listen to their life.
Well, Rita, we're about out of time again, and I just want to kind of review some things here before we go. Is number one, it's a person's choice whether they're in or out, and it has to do with treatment or anything. They have that choice, right?
Yes, it's all about choice.
You're right, and that hospice is for all areas of disease. It's not just for cancer, as so many people think it is.
Right.
And that it's not only home care, it's nursing home and hospital also. Now, I know I've left out a lot. Anything you would like to add, some of the highlights that we just might want to quickly say like that, 2, 3, 4, but that is for anybody and everybody.
Right, it is.
And what
And
counties?
the team approach.
And we have 10 counties?
10 in Kentucky and 3 in Illinois. We serve 13.
Okay, and that's primarily the western area
Right, Western
that we
Kentucky
have.
area.
All right, well, we're going to wrap up here, and we want you to know that one of the major emphasis for this program has been to educate you, to give you the knowledge that you need about Lourdes Hospice Program here in Western Kentucky, and that we want to encourage you to volunteer. We encourage you to call Susan Mason, who's the volunteer coordinator, whose number is up on the screen, and we want you to be involved in this program. It'll benefit you as much, if not more, than it will the people that you're working with. And I think that's important, that we know that someone has said one time that there's no greater good that you can do than helping someone else, and that's important. So we encourage you to write. We encourage you to get in touch with Susan. We encourage you to let us know about our programs. You can reach us on the web at thefabulousfifties.net, and that's 50 spelled out. Or you can write us, and our address is
P.O. Box 7, Bowes, Kentucky, 42027.
Remember now, use it or lose it.
Can't see as well as I used to. Can't run as far or as fast. Sometimes I think that the old me is becoming exactly that. But when I start thinking